Thank you. I'm going to ask Dr. Walker to come up, CTO crossing, choice of wires and techniques.
Yeah, so all I was asked to do was speak about wires. And obviously I have hour-long talks on wires, and these are my disclosures. But why speak about guide wires? Well, we have to access lesions, we have to cross lesions, and we have to deliver devices. And if we can't do these things, you can't treat the patient. So no matter what access you use, no matter where you come from, wires are an integral part of every intervention that we use. And when I'm choosing a wire, I think about many things. The length of the wire, because, for instance, in a radio case, you really need a long wire. And if you don't have that to start with, you get very frustrated. Diameter, tip penetrance, torqueability, shaft support, shaft flexibility, visibility, coating sleeves, tip shapeability, the retention of that tip, device compatibility, because you have to make sure your device will fit over, the cost of the wires. We're in a scrutinizing time, so we have to watch this, and the durability of a wire. If they're flimsy and fall apart, that's a problem. Now, there are guide wire key components which we all look at, but let's look at those one at a time. So let's look at the core material. Core material, historically, the first core material was regular stainless steel and ultimately high tensile stainless steel. Now, the characteristics of that is that it's very torqueable. It is rigid, and it has better columnar support for delivering devices. Another type, however, is nitinol. Nitinol is more flexible. It will not kink. So albeit it doesn't have the same support, it doesn't kink, and kinking is often what tears vessels when we're putting sheaths in. And now we have hybrid wires which incorporate the best of both worlds, stainless steel so that we can torque it better, nitinol to where we don't get kinks, and this is important. And so we also have other things being added. We have new generation composite micro braids using wires that are 10 microns in diameter. Let's put that in perspective. A red blood cell is 5 microns in diameter. So using these tiny wires twisted, which allow us to torque beautifully. Now, what do we do with a wire? We can advance it, we can pull it back, and we can torque it. That's really what we're going to do with a wire. Now, let's look at core diameter of a wire. So when we talk about an 035 wire, we're speaking about a diameter wire of 035. And so it has a core, and the larger the diameter, the better will be the real support and the torque. And this may enable vessel straightening and allow you to place sheaths and things such as that. Now, the strength of a wire is related to the fourth power of the radius. So someone says, well, how much difference is there between an 018 and an 014? Because it's the fourth power of the radius. Okay, an 018 has 2.73 times the columnar shaft support, assuming it's made of the same material, as does in 0.014, so a lot more support. So now where is the fact that core diameter actually may not result in better torque? Well, in tortuosity, because it's big, it's stiff, and then we get frictional elements that play a role because of those bends. And most atherectomy devices require 0.014s. Now, how do we make a wire more flexible? We make it thinner. We grind it. And we have things which are called tapers, going from the big core to smaller. And then we have a grind. A grind is an area of constant diameter. Then we can have another taper here. And by the end, we end up with something that's flexible at the tip. That's how we make a wire more flexible. And then you see an outer coil in this case, and you see space in between. Now, these tapers are important. Broad, gradual, or long tapers allow us to come up and over acute bends and get the wire gradually across to where it simply does not prolapse, in this case, up the aorta, but in other areas. Whereas a short taper allows us, by putting a wire in just a very short distance, to still be working over a very supportive part of the wire to deliver our tools. Now, if you wonder about the tapers of your wire, pretty much every wire made comes with a Guidewire support chart. Most of us take this out and throw it in the bottom of the garbage can as soon as we see it, but that's probably not what we should do. Because if you look at this, you can see it tells you where these tapers are. And it gives you an idea of how likely your wire is to make it around very tortuous bends and other things. Now, what about tip design? I think really, when I speak of very complex intervention, nothing is more important to me than the tip of that wire. The tip of that wire is going to interact with the plaque that I'm crossing. And when I get beyond that crossing, It may destroy the distal vessel if I'm not careful, or if I've chosen too aggressive a tip that would let me get through a very hard lesion. But perhaps if that wire migrates just a little bit at the end, we can have wire perforations and not such a good result. Now, in basic ideas, when we look at tip designs, we break them into two types, core to tip and those which have a distal shaping ribbon. And what you can see is core to tip going along the central axis. The wire ultimately extends all the way to the tip. And as you might imagine, this gives us better force of transmission. It gives us better steerability. It gives us better tactile feedback. It's ideal for peripheral vessels, and it's quite durable. And as we look at shaping ribbons, they're easy to shape. They shape much better at the end. They're soft, and so these are used a lot in coronary cases. They prolapse a bit more easily because that ribbon is so soft, but they're much more delicate. Now, something has just recently changed in even the core to tip wires. Asahi has made much of these designs. And so they've built in flex points in some of their core to tip wires. One of those points on, for instance, a Mongo ES 14000s will give one a 1 millimeter controlled J if you push the wire. That's fantastic when you're treating a very long, totally occluded infrapopliteal vessel. It often can cross those. I can show you pictures where we've crossed densely calcified 30 centimeter occluded infrapopliteal vessels in a matter of seconds. And it goes through because it's a small controlled J. Their 18,000s wires have a flex point, allowing a 3 millimeter J to be created. Once again, in a slightly bigger vessel, this allows one a subintimal passage that's fairly quick and allows us to stay within the vessel. Now, all of us talk about tip penetrance and the ability to cross total occlusions. And what is tip penetrance? It's pressure. And pressure in physics term is just simply force per unit area. So the stiffer we make the wire, the greater is the force. The more we sharpen the tip of the wire, the less will be the area. So if we want greatest penetrance, we use a very stiff wire up to that point, we sharpen the tip. Some of our European colleagues use this. They use very, very stiff wires, and they get there and they cut it at an angle with things, giving them sometimes force penetrance of hundreds of grams of force penetrance. We don't do that here. We'd probably get into deep trouble sometimes if someone saw us doing that. But you can see the basic physics of what we're doing to create penetrance is we use a stiffer wire and we may sharpen it. So for instance, the Halbert wire that you saw today is fairly stiff and it has a tapered tip. That tapered tip behaves more like the tip of an ice pick would rather than the shaft of the ice pick in terms of making ability to deal with this. The other area that we've really had tremendous advantage in these wires, in these tips, are the coils and the covers. And these are placed around the ends so that we can see the vessels. So Guidewire tips and coils, they affect support, steering, tracking, and visibility. They let us see the tip. Because if you can't see the tip, you really don't have a good clue where you're going. There's a new concept that's come out, and it's called Act 1 technology. There's also a twist wire technology that's very impressive. But Act 1 technology is a microbraid hypotube placed between the outer coils and the sharpened off end point of the central core of a wire. So that fills that empty space, making it less likely to get deformed. It improves our ability to torque. And then you can add on top of that a 7-wire microbraid called a twist wire. And so in a 14,000ths Xi'an black wire, there are 15 wires if you count the coil and you count what happens here. These are tiny wires, but what you have is 1-to-1 torque, even after you go around as many as 8 hairpin bends, 1-to-1 torque at the end. This is very important because remember what you do with a wire. You push it forward, you pull it back, or you torque it. That's what you're doing. And torquing is 1/3 of the battle. So companies are coming around and helping this. Now, also, these outer coils can affect the dimension of the wire. In coronary cases, for instance, or in cases where we have a true lumen, and we want to make sure that our wire does not inadvertently go into the wrong path, tactile feedback is important. So in that case, we don't want a wire to slip into other places and perhaps go subintimal. We want something that we can accurately place and be certain that we're going to keep it true luminal. And in those cases, when we place that wire distally, that wire is far less to cause a perforation because it has greater resistance at that point. Now, we have other things that we can do at the end. The way that we can make a wire absolutely have the lowest coefficient of friction is if we place a polymer or a plastic over those coils at the end. Why? Those coils have ridges to them. Now we're putting a smooth surface over there, and we smooth out the ridges. Ridges cause frictional elements. And so we get rid of those frictional elements. And if we use something like a hydrophilic polymer jacket, then that attracts water. It has an extraordinarily low coefficient of friction, similar to that of an ice skate on ice. And that provides profound lubricity. So now we've gotten rid of coefficient of friction, and we have something which will slide through even greatest tortuosity with ease. And this gives us smooth tracking through tortuosity. It smooths out the ridges of a coil, and that should not be confused with a hydrophilic coating, which is simply a spray-on coating, but does not get rid of the ridges on the wire tip. Now, we use these in combinations now. So we can use tip coils plus intermediate coils, bare cover, plastic cover, polymer covers, and we can put polymer over the tip coils to make it really slip through very well. Very important to know this. I am writing right now a little book looking at wires and how we should approach wires, but knowing wires is pretty crucial, and this is a lot of science to work with this. And then finally, we have these coatings. And the first coatings that came out were silicone. They're hydrophobic. They repel water. And this creates a wax-like surface. When you first use these, they slide through things reasonably better than just the metal, and they don't require any actuation. So they do reduce friction, and they provide improved trackability. However, they're not as slippery as a wet hydrophilic coating. As I've mentioned before, measured coefficients of friction here are amongst the lowest that one can find in terms of frictional coefficients. Now, when wet, these are slippery as hell. But when you're using these, be careful. Because when they're dry, they're mucopolysaccharide, they're sugar. And so what happens is they're as sticky when they're dry as they are slippery when they're wet. And if you don't carefully wipe these off, no matter how strong you are holding that wire, you can pull it out in a heartbeat. So you have to consider that. So this is what we do as we look at lubricity and tactile feedback. And we have to pick and choose our cases and say, which will be the ideal wire to use? And that's why it's so important to look at wires. Finally, we have to see these. And how do we do that? We put materials we see, and we use platinum, palladium, tungsten, and even just stainless steel sometimes. And how much of the material we put, how thick of material we put affects radio opacity, but some of these, particularly platinum, are beautifully radio opaque, and we can see them very nice. Now, how we shape a wire also matters. Penetrating the lesion entry point, one wants a straight or a small angle at the very distal tip. This gives us better penetrance because we lose pressure at the end of the tip, the greater the bend. It's just simply vector physics, once again. If we need to torque a wire, we'll put a secondary bend. This allows us to navigate through tortuosity. And when we're trying to perform subintimal crossing, or we may do this on the fly with some of these new wires that have built-in flex points, then we want a J, because that allows us to feel our way through and is less likely to penetrate through the side of a vessel. So how do guide wires fail to cross? Well, the wire tip gets to a hard lesion, but it simply won't enter that lesion. The lesion's too hard. What can we do for that? Well, we can use a wire with a higher tip gram load. We can use a sharp angle. Or we can use a support catheter. Something I've not mentioned, if we put a support catheter all the way up to this plaque and we push, whenever we talk about tip penetrance, that's typically measured with a support catheter 1 to 2 centimeters back from the area that you're intending to work. Well, if you advance that support catheter all the way to the lesion, you're going to have far greater tip penetrance. So you can increase penetrance by using a catheter on the outside of this to give columnar shaft support. Or the proximal segment, you enter, but then it starts to buckle. Well, what you can do here? You can use a wire with a higher tip gram load, or you can use a hydrophilic coating because that will slide through a little better. Or once again, you can advance a support catheter to the very, very tip of this, and that will again push, give you greater penetrance. Or the tip enters the lesion and goes fairly well into it, but the wire fails to follow. Well, you can once again use a wire with a higher rail support, or a lower profile wire, or a hydrophilic wire, or you can advance a support catheter further into this and see if this same wire will go together. Or the wire crosses, but now the device fails to cross. Well, you can use a wire with a higher rail support because you can use one that's, even though it may not be thicker, it may be of a stronger material. Or you can use a lower profile system. So you might have crossed with an 035 wire, you exchange out for an 014 and use 014 systems. Those will typically cross. And as Lake showed you today, once he crossed that very calcified lesion, his IVUS crossed pretty easily. By having crossed with that 035 catheter, he's made a pilot channel. So I think there are a lot of keys to success. Wire escalation, you've got to pick wires for what you're going to do. And sometimes you need higher penetrance. Sometimes you need to, once you've crossed the lesion, get rid of that high penetrance wire and put a soft tip wire at the end. Wire exchanges is necessary. Wire selection for penetrating the cap versus navigating the middle of the lesion versus device delivery. You have to think about these a priori. Shaping the tip, crucial. I like to do this myself, but I also like some of the pre-shaped tips that come from some of the companies where we can get an accurate 1 millimeter tip. Use of a support cath, and finally access. Access affects push, torque, reach, support, visualization. It allows us to get into hibernating vessels. It allows us to get closer to lesions. It allows us to approach a proximal cap and avoid collateral vessels. So in conclusion, treating complex lesions is challenging. Wires can fail in many ways. They can fail to cross, to deliver a device, or cause distal injury. And I didn't speak enough about that today, but we have to be cognizant of that because often where we're working is very far from the very distal end of the wire. And we're looking at where we're working. Often we're not paying attention to that distal wire. And it's very important to have a wire that will not injure when we can't see it. Familiarity with a multitude of wires can benefit in, I think, all cases. And understanding wire technical attributes and impact on clinical performance can help us choose the right wire in the right case. And often if we choose right, one wire will get us through everything. And many non-wire factors, i.e. support catheters, i.e. access, can affect the outcomes, not just the wire itself. And I made it with 20 seconds to spare. I didn't think I had a chance in hell of that. And we'll move on to our next talk.
Yes, thank you. Thank you, Dr. Walker.